Question 1. A 62-year-old male presents with sudden onset of severe crushing chest pain, diaphoresis, and shortness of breath. His ECG shows ST segment elevation in leads V2-V4. What is the immediate priority for this patient, assuming hospital arrival? A. Administer morphine to alleviate pain. B. Obtain immediate cardiac enzyme levels. C. Prepare for immediate reperfusion therapy. D. Initiate antiplatelet therapy with aspirin and AP2Y12 inhibitor. Answer: C. Prepare for immediate reperfusion therapy. This question tests your understanding of acute coronary syndromes, particularly ST elevation myocardial infarction, STEMI, where ST segment elevation is a critical clue. For STEMI patients, the primary goal is to restore blood flow to the heart muscle as quickly as possible through reperfusion therapy, such as percutaneous coronary intervention, PCI, or fibrinolytic therapy. While pain relief, enzyme levels, and antiplatelet therapy are important, they do not take precedence over the immediate need for reperfusion to limit myocardial damage. For example, getting the patient to the cath lab for PCI within the recommended door-to-balloon time is paramount. Always remember that time is muscle in STEMI, making reperfusion the most time-sensitive intervention. Question 2. A 70-year-old patient in the emergency department suddenly collapses. You initiate CPR. A rhythm check reveals asystole. The patient has no palpable pulse. What is the next immediate intervention after confirming asystole and pulselessness? A. Administer 1 mg of atropine intravenously. B. Administer 1 mg of epinephrine intravenously. C. Prepare for immediate defibrillation. D. Continue CPR and assess for reversible causes. Answer: B. Administer 1 mg of epinephrine intravenously. This question addresses the pulseless asystole algorithm in cardiac arrest. The key here is asystole, which means there is no electrical activity to shock. After confirming pulselessness and beginning high-quality CPR, the primary pharmacological intervention for asystole, as well as pulseless electrical activity, PEA, is to administer epinephrine every 3 to 5 minutes. Defibrillation is not indicated for asystole because there is no organized electrical activity to reset. Continuing CPR while looking for reversible causes is also important but occurs concurrently with drug administration. For instance, you would give epinephrine while other team members investigate for H's and T's. Remember, for asystole, think AP, it's the main drug to try and get the heart started. Question 3. During cardiac arrest, you are managing the airway with a bag mask device. After placing an advanced airway, what is the recommended ventilation rate? A. 10 to 12 breaths per minute, continuously. B. 8 to 10 breaths per minute, continuously. C. 1 breath every 6 to 8 seconds, synchronized with compressions. D. 1 breath every 5 to 6 seconds, unsynchronized with compressions. Answer: D. 1 breath every 5 to 6 seconds, unsynchronized with compressions. This question focuses on ventilations during cardiac arrest once an advanced airway is in place, which is a common area of confusion. When an advanced airway, like an endotracheal tube or LMA, is inserted, compressions become continuous, and ventilations are given at a rate of 1 breath every 5 to 6 seconds, without pausing compressions. The keyword unsynchronized is crucial because it differentiates this from bag mask ventilation, which requires pausing compressions for breaths. For example, if CPR is ongoing with an ET tube, the person doing compressions will continue uninterrupted while the person managing the airway delivers breaths every 5 to 6 seconds. Always aim for continuous compressions and avoid hyperventilation when an advanced airway is present. Question 4. A 45-year-old male presents with lightheadedness and a heart rate of 35 bpm. His blood pressure is 80/40 mmHg, and he is pale and diaphoretic. What is the initial intervention? A. Administer 0.5 mg atropine 4. B. Prepare for transcutaneous pacing. C. Administer 6 mg adenosine 4 rapid push. D. Administer 1 mg epinephrine 4. Answer: A. Administer 0.5 mg atropine 4. This scenario describes symptomatic bradycardia, where lightheadedness, low blood pressure, and pale and diaphoretic indicate instability, and heart rate of 35 bpm points to bradycardia. The initial pharmacological treatment for symptomatic bradycardia is atropine, given at a dose of 0.5 mg intravenously, repeated every 3 to 5 minutes up to a total of 3 mg. While transcutaneous pacing is an option for symptomatic bradycardia, atropine is the first-line drug intervention if there is no immediate indication for pacing, like a high-degree AV block where atropine might be ineffective. For example, after assessing for signs of instability, giving atropine is the very first step in the bradycardia algorithm. Always remember that atropine is the drug of choice for bradycardia unless it's a specific type of block. Question 5. You are managing a patient in ventricular fibrillation. After the first defibrillation, what is the immediate next step, assuming the patient remains in VF? A. Check for a pulse. B. Administer 1 mg epinephrine 4. C. Immediately resume high-quality CPR. D. Prepare for a second defibrillation. Answer: C. Immediately resume high-quality CPR. This question focuses on the post-defibrillation sequence in cardiac arrest. The crucial concept is that after any defibrillation attempt, regardless of the rhythm or whether it was successful, high-quality chest compressions must be immediately resumed for 2 minutes without checking a pulse or rhythm first. This ensures continuous blood flow to the brain and heart. The phrase "remains in VF" is a distractor, as the action is the same whether the rhythm changed or not. For instance, as soon as the shock is delivered, hands should be back on the chest, continuing compressions while the defibrillator recharges. Always prioritize immediate CPR after a shock to maximize myocardial perfusion. Question 6. A patient in cardiac arrest has achieved return of spontaneous circulation, ROSC. Which of the following is the most important initial management goal post-ROSC? A. Maintain a systolic blood pressure greater than 90 mm of mercury. B. Achieve a core body temperature of 33 degrees Celsius. C. Prepare for immediate diagnostic angiography. D. Administer routine prophylactic antiarrhythmics. Answer: A. Maintain a systolic blood pressure greater than 90 mm of mercury. This question tests your knowledge of immediate post-cardiac arrest care. Upon achieving ROSC, the absolute priority is optimizing hemodynamics and ventilation to prevent secondary brain and organ injury. Maintaining a systolic blood pressure above 90 mm of mercury, or mean arterial pressure above 65 mm of mercury, is crucial to ensure adequate perfusion to vital organs, especially the brain. While targeted temperature management, TTM, to 33 degrees Celsius is important for some patients, it is a later step, not the immediate primary goal. For example, if a patient achieves ROSC, immediate focus shifts to ensuring they have a good blood pressure, often requiring fluids or vasopressors. Remember, adequate perfusion is fundamental for post-ROSC stability. Question 7. You are assessing a patient who is unconscious and unresponsive. You suspect an opioid overdose. Which medication is indicated for reversal? A. flumazenol, B. atropine, C. naloxone, D. activated charcoal. Answer: C. naloxone. This question addresses a specific reversible cause of cardiac arrest or respiratory depression, opioid overdose. The key phrase opioid overdose directly points to the antidote. Naloxone is an opioid antagonist used to reverse the effects of opioid toxicity, especially respiratory depression. Flumazenol is for benzodiazepine overdose, and atropine is for bradycardia. For example, if a patient is found unresponsive with pinpoint pupils and slow breathing, administering naloxone is a critical intervention that can rapidly reverse these life-threatening effects. Always keep naloxone in mind when an opioid overdose is suspected. Question 8. A 55-year-old male with a history of heart failure presents with rapid, irregular, wide complex tachycardia at a rate of 170 bpm. He is hypotensive, BP 70/40 mmHg, and acutely confused. What is the most appropriate immediate intervention? A. Administer amiodarone 150 mg for over 10 minutes. B. Administer adenosine 6 mg for rapid push. C. Perform synchronized cardioversion. D. Prepare for immediate defibrillation. Answer: C. Perform synchronized cardioversion. This question describes symptomatic wide complex tachycardia, which is a critical emergency. The key elements are wide complex tachycardia, rapid, irregular, and especially the signs of instability, hypotensive and acutely confused. When a patient with tachycardia shows signs of instability, hypotension, altered mental status, signs of shock, acute heart failure, ischemic chest discomfort, immediate synchronized cardioversion is the treatment of choice, regardless of whether it's regular or irregular. Adenosine is typically for narrow complex tachycardias or regular wide complex tachycardias that are stable. For example, if a patient is crashing from a fast heart rate, shocking them back to a normal rhythm is the quickest way to stabilize them. Remember, unstable tachycardia equals shock. Question 9. What is the primary method used to confirm and monitor the correct placement of an endotracheal tube in cardiac arrest? A. Bilateral chest auscultation. B. Visualization of condensation in the tube. C. Continuous quantitative waveform capnography. D. Esophageal detector device. Answer: C. Continuous quantitative waveform capnography. This question asks about the most reliable method for confirming endotracheal tube placement. While other methods like bilateral chest auscultation and visualizing condensation are useful adjuncts, continuous quantitative waveform capnography is the most accurate and reliable method for confirming and monitoring tube placement, as it detects exhaled carbon dioxide. If you see a persistent waveform, the tube is in the trachea. For instance, after intubating a patient in cardiac arrest, watching the capnography waveform appear on the monitor immediately tells you if the tube is in the right place. Always rely on capnography as your primary tool for confirming ETT placement. Question 10. A patient experiences sudden cardiac arrest. High-quality CPR is initiated immediately. The AED analyzes and advises no shock advised. What is the next immediate step? A. Recheck pulse and rhythm. B. Administer 1 mg epinephrine 4. C. Immediately resume high-quality CPR. D. Discontinue CPR and assess for breathing. Answer: C. Immediately resume high-quality CPR. This question tests the appropriate response to an AED analysis that advises no shock advised. Whether the AED advises a shock or not, if the patient remains in cardiac arrest, the most crucial next step is to immediately resume high-quality chest compressions for 2 minutes. This ensures minimal interruptions in blood flow to vital organs. Checking a pulse or administering medications should only occur after a 2-minute cycle of CPR. For example, as soon as the AED gives its advice, your hands should be back on the chest, resuming compressions without delay. Always remember, uninterrupted high-quality CPR is paramount. Question 11. During a pulseless arrest scenario, a 68-year-old patient has been in ventricular fibrillation for 5 minutes. After 2 shocks and continuous CPR, the patient remains in VF. What is the next appropriate medication to administer, assuming epinephrine has already been given? A. Lidocaine 1 to 1.5 mg/kg4. B. Atropine 1 mg 4. C. Amiodarone 300 mg 4 bolus. D. Magnesium sulfate 1 to 2 g4. Answer: C. Amiodarone 300 mg 4 bolus. This question targets the refractory ventricular fibrillation (VF) algorithm. The key information is that the patient remains in VF after 2 shocks and continuous CPR, and epinephrine has already been given. In adult VF/pulseless VT that is refractory to defibrillation and epinephrine, the first-line antiarrhythmic is amiodarone, given as a 300 mg 4 bolus. Lidocaine is an alternative if amiodarone is not available or contraindicated. For instance, if the patient is still in VF after the initial shock and AP, amiodarone is the next drug you'd consider to help convert the rhythm. Remember, amiodarone is the primary antiarrhythmic for persistent VF. Question 12. Which of the following is considered a non-shockable rhythm in adult cardiac arrest? A. Ventricular fibrillation, VF. B. Pulseless ventricular tachycardia, private. C. Asystole. D. Ventricular tachycardia with a pulse. Answer: C. Asystole. This question asks to identify a non-shockable rhythm in cardiac arrest, which is a fundamental concept. Non-shockable rhythms include asystole, complete absence of electrical activity, and pulseless electrical activity, PEA, organized electrical activity without a palpable pulse. Ventricular fibrillation, VF, and pulseless ventricular tachycardia, private, are shockable rhythms. Ventricular tachycardia with a pulse is not a cardiac arrest rhythm and may be treated with synchronized cardioversion or medication, not defibrillation. For example, if you see a flat line on the monitor, you know defibrillation won't work, so you focus on CPR and medications like epinephrine. Always remember, if there's no organized electrical activity or no pulse with organized activity, don't shock. Question 13. A 28-year-old pregnant patient in her 3rd trimester collapses and is pulseless. High-quality CPR is initiated. What is a crucial modification to chest compressions for this patient? A. Displace the uterus to the patient's left. B. Perform compressions higher on the sternum. C. Increase compression depth to 3 inches. D. Deliver ventilations at a slower rate. Answer: A. Displace the uterus to the patient's left. This question specifically addresses cardiac arrest in pregnancy, which requires unique modifications. The key phrase "pregnant patient in her 3rd trimester" indicates the need for uterine displacement. Manually displacing the uterus to the patient's left is crucial to relieve aortocaval compression, which improves venous return and cardiac output during CPR, benefiting both the mother and the fetus. Other options are either incorrect or not specific to pregnancy. For example, as CPR begins, a team member should be assigned to manually push the uterus to the side to optimize blood flow. Always remember to displace the uterus in pregnant cardiac arrest patients to improve CPR effectiveness. Question 14. A patient presents with acute onset of narrow complex tachycardia at a rate of 190 bpm. He is alert, oriented, and his blood pressure is 120/80 mmHg. Vagal maneuvers have been attempted and failed. What is the next most appropriate intervention? A. Administer 6 mg adenosine for rapid push. B. Prepare for synchronized cardioversion. C. Administer diltiazem 15 to 20 mg for. D. Perform carotid sinus massage again. Answer: A. Administer 6 mg adenosine for rapid push. This question describes stable narrow complex tachycardia, characterized by narrow complex tachycardia at a rate of 190 bpm and the patient being alert, oriented, and his blood pressure is 120/80 mmHg, indicating stability. After failed vagal maneuvers, the first-line medication for stable narrow complex tachycardia, likely supraventricular tachycardia, SVT, is adenosine, given as a 6 mg rapid 4 push. Synchronized cardioversion is reserved for unstable tachycardias, and calcium channel blockers like diltiazem are typically second-line or for other rhythms. For instance, after attempting a Valsalva maneuver without success, giving adenosine is the next immediate step to try and break the SVT. Always remember that adenosine is the go-to drug for stable narrow complex SVT. Question 15. A patient has been intubated, and you are monitoring continuous quantitative waveform capnography. You notice a sudden, significant drop in the end-tidal CO2, EtCO2, reading from 40 mm of mercury to 10 mm of mercury, despite continued CPR and no change in rhythm. What is the most likely cause? A. Return of spontaneous circulation, ROSC. B. Dislodgement of the endotracheal tube. C. Improvement in chest compression quality. D. Airway obstruction. Answer: B. Dislodgement of the endotracheal tube. This question tests your interpretation of capnography during cardiac arrest. A sudden, significant drop in EtCO2 during ongoing CPR, especially without ROSC, is a strong indicator of endotracheal tube dislodgement or a leak. A drop in EtCO2 to 10 mm of mercury during CPR without ROSC suggests that CO2 is no longer being adequately exhaled, often because the tube is no longer in the trachea. While a sudden increase in EtCO2 can indicate ROSC, a significant drop suggests a problem with the airway or ventilation. For example, if the EtCO2 abruptly falls, the immediate action is to check the tube's position and reassess ventilation. Always consider tube dislodgement when EtCO2 suddenly drops during CPR. Question 16. What is the recommended chest compression depth for an adult during high-quality CPR? A. At least 1 inch 2.5 centimeters. B. At least 1.5 inches 3.8 centimeters. C. At least 2 inches 5 centimeters. D. At least 2.5 inches 6.4 centimeters. Answer: C. At least 2 inches 5 centimeters. This question assesses a fundamental component of high-quality CPR. For adults, the recommended chest compression depth is at least 2 inches 5 centimeters but no more than 2.4 inches 6 centimeters. Compressing deep enough is crucial for generating adequate blood flow to the vital organs, particularly the brain and heart. Too shallow compressions are ineffective, while excessively deep compressions can lead to injury. For example, when you perform chest compressions, aim to push down firmly and quickly to ensure you reach the proper depth. Always remember, at least 2 inches, no more than 2.4 inches for adult compression depth. Question 17. A patient in cardiac arrest has a presumed diagnosis of hypothermia. After initiating CPR and warming interventions, what is the key consideration regarding defibrillation attempts? A. Only one defibrillation attempt is recommended. B. Defibrillation attempts should be withheld until core temperature is greater than 30 degrees Celsius. C. Up to 3 shocks are recommended before core temperature is greater than 30 degrees Celsius. D. Defibrillation is contraindicated in hypothermic cardiac arrest. Answer: C. Up to 3 shocks are recommended before core temperature is greater than 30 degrees Celsius. This question addresses the specific management of cardiac arrest due to hypothermia. In hypothermic cardiac arrest, defibrillation may be ineffective at very low core body temperatures. The guideline states that up to 3 defibrillation attempts are recommended for shockable rhythms before the core temperature reaches 30 degrees Celsius. After 3 shocks, additional defibrillation attempts should be deferred until the patient's core temperature is above 30 degrees Celsius and further warming has occurred. For example, if a patient is found severely hypothermic and in VF, you would deliver the initial 3 shocks, but then focus heavily on warming before attempting more shocks if VF persists. Remember, warming is paramount in hypothermic arrest, but initial shocks are still appropriate. Question 18. You are managing a patient with suspected acute stroke. The patient arrived at the emergency department 2 hours ago. Which of the following is a critical initial action for this patient? A. Administer aspirin immediately. B. Obtain an immediate non-contrast head CT scan. C. Prepare for immediate fibrinolytic therapy. D. Start continuous cardiac monitoring. Answer: B. Obtain an immediate non-contrast head CT scan. This question focuses on the initial management of acute stroke, where suspected acute stroke and arrived 2 hours ago are critical time-sensitive clues. The absolute priority for a suspected stroke patient is to obtain an immediate non-contrast head CT scan to differentiate between ischemic stroke and hemorrhagic stroke. This distinction is crucial because fibrinolytic therapy, clot-busting drugs, is only indicated for ischemic stroke and is contraindicated in hemorrhagic stroke. For example, upon arrival, the patient should be fast-tracked to the CT scanner to determine the type of stroke before any targeted treatment is initiated. Always remember that a CT scan is the immediate priority to rule out hemorrhage before considering fibrinolysis. Question 19. A 75-year-old patient with an acute myocardial infarction develops severe pulmonary edema and hypotension. What is the most appropriate initial pharmacological intervention to improve hemodynamics? A. Nitroglycerin. B. Furosemide. C. Norepinephrine. D. Dobutamine. Answer: C. Norepinephrine. This question describes a patient with acute myocardial infarction complicated by both severe pulmonary edema, suggesting pump failure/cardiogenic shock, and hypotension. The key is hypotension, which signifies inadequate perfusion. While nitroglycerin and furosemide might be used for pulmonary edema, they can worsen hypotension. Dobutamine is a positive inotrope that can help pump function but might also lower blood pressure initially. Norepinephrine is a potent vasoconstrictor and inotrope that is the first-line vasopressor for cardiogenic shock when hypotension is present, as it increases blood pressure and systemic vascular resistance. For example, if the patient's blood pressure is dangerously low despite fluid challenges, starting norepinephrine helps to stabilize the circulation and improve perfusion to vital organs. Prioritize correcting severe hypotension in cardiogenic shock. Question 20. Which of the following is the most appropriate action for a patient who has a perfusing rhythm but remains unconscious after cardiac arrest and achieving ROSC? A. Initiate targeted temperature management, TTM. B. Obtain immediate neurosurgical consultation. C. Administer prophylactic antiarrhythmics. D. Prepare for immediate thrombolytic therapy. Answer: A. Initiate targeted temperature management, TTM. This question addresses the post-cardiac arrest care for patients who remain unconscious after ROSC. The key phrase "remains unconscious" indicates a need for brain protection. Targeted temperature management, TTM, which involves cooling the patient to a specific temperature, e.g., 32 to 36 degrees Celsius for at least 24 hours, is a critical intervention for comatose adults with ROSC to improve neurological outcome and survival. While other considerations are important, TTM is a standard and crucial neuroprotective strategy. For example, once the patient is stable post-ROSC, the team should begin preparing to cool the patient to the target temperature. Always consider TTM for comatose post-cardiac arrest patients to protect the brain. Question 21. You are leading a resuscitation team. Which communication technique is most effective for ensuring tasks are completed accurately and efficiently? A. Open-ended questions to all team members. B. Speaking loudly to ensure everyone hears. C. Closed-loop communication. D. Asking team members if they understand their roles. Answer: C. Closed-loop communication. This question focuses on effective team dynamics during resuscitation. Closed-loop communication is the most effective technique for ensuring tasks are understood and completed. It involves the sender giving a clear message, the receiver acknowledging and repeating the message, and the sender then confirming that the message was received correctly. This prevents misunderstandings and ensures accountability. For example, if you say, "Give 1 milligram of epinephrine," the nurse would say, "Giving 1 milligram of epinephrine," and you would confirm, affirmative, 1 milligram epinephrine given. Always use closed-loop communication to enhance team performance and patient safety. Question 22. A patient with pulseless electrical activity, PEA, has been receiving high-quality CPR and epinephrine. What is the most critical next step in managing PEA? A. Administer atropine. B. Prepare for immediate synchronized cardioversion. C. Identify and treat reversible causes. D. Increase the frequency of epinephrine administration. Answer: C. Identify and treat reversible causes. This question addresses the management of pulseless electrical activity, PEA. The key difference in PEA compared to shockable rhythms is that defibrillation is not effective, making the identification and treatment of reversible causes, the H's and T's, paramount. While CPR and epinephrine are ongoing, the team should actively search for and treat conditions like hypovolemia, hypoxia, hydrogen ion, acidosis, hypothermia, hypo/hyperkalemia, tension pneumothorax, tamponade, toxins, thrombosis, pulmonary or coronary. For example, if you suspect hypovolemia as a cause, rapidly administering intravenous fluids could potentially reverse the PEA. Always prioritize finding and fixing the underlying problem in PEA. Question 23. A 40-year-old male with a history of intravenous drug use is found unresponsive with shallow, slow respirations, 6 breaths/minute, and pinpoint pupils. What is the most appropriate initial treatment? A. Initiate chest compressions. B. Administer 100% oxygen via non-rebreather mask. C. Administer naloxone. D. Prepare for immediate intubation. Answer: C. Administer naloxone. This question describes an opioid overdose, with history of intravenous drug use, shallow, slow respirations, and pinpoint pupils being classic signs. The most appropriate initial treatment is to administer naloxone, which is an opioid antagonist that can rapidly reverse the respiratory depression caused by opioids. While oxygen is important, addressing the underlying respiratory drive failure is critical. Chest compressions are only initiated if the patient is pulseless. For example, if you encounter someone with these signs, your first thought should be naloxone to restore their breathing, often given intranasally or intramuscularly by lay rescuers, or intravenously by healthcare professionals. Always remember that naloxone is the priority for suspected opioid overdose with respiratory depression. Question 24. What is the recommended duration of a single pulse check during CPR? A. No less than 5 seconds, no more than 10 seconds. B. At least 10 seconds, no more than 15 seconds. C. No more than 5 seconds. D. At least 15 seconds. Answer: A. No less than 5 seconds, no more than 10 seconds. This question tests a crucial detail of high-quality CPR to minimize interruptions. The recommended duration for a pulse check is no less than 5 seconds and no more than 10 seconds. A pulse check longer than 10 seconds causes excessive interruptions in chest compressions, which significantly reduces the effectiveness of CPR. For example, when you pause compressions for a rhythm check, quickly feel for a pulse for no more than 10 seconds before resuming compressions if no pulse is found. Keep pulse checks brief to maximize hands-on time. Question 25. A patient presents with acute onset of severe headache, unilateral facial droop, and left-sided weakness. The last known well time was 3 hours ago. What is the most critical time-dependent intervention to consider? A. Administration of aspirin. B. MRI of the brain. C. Intravenous fibrinolytic therapy. D. Carotid endarterectomy. Answer: C. Intravenous fibrinolytic therapy. This question describes a suspected acute ischemic stroke, with severe headache, unilateral facial droop, and left-sided weakness being classic symptoms, and last known well time was 3 hours ago, putting the patient within the typical treatment window. After a non-contrast head CT rules out hemorrhage, intravenous fibrinolytic therapy, e.g., alteplase, is a critical time-dependent intervention for eligible patients within the therapeutic window, usually 3 to 4.5 hours from last known well time. The goal is to dissolve the clot and restore blood flow to the brain. For example, once the CT confirms ischemic stroke, administering the clot-busting medication quickly is paramount. Time is brain in stroke, so prompt evaluation for fibrinolysis is key. Question 26. A 50-year-old male is in cardiac arrest. The rhythm is ventricular fibrillation. After delivering the first shock, the patient remains in VF. What is the correct energy dose for the second shock using a biphasic defibrillator? A. 120 to 200 J. B. 200 J. C. 300 J. D. The same energy dose as the first shock. Answer: B. 200 J. This question specifically asks about the energy dose for subsequent shocks in VF/private using a biphasic defibrillator. For biphasic defibrillators, the initial shock typically ranges from 120 to 200 J. If the first shock fails, subsequent shocks should be at an equal or higher dose, with the maximum being 200 J for most biphasic devices. Therefore, 200 J is a common choice for the second and subsequent shocks if the device manufacturer's maximum dose is 200 J. For example, if your device gave a 120 J shock, The next one should be at least 120 J, but often protocols advise escalating to the maximum of 200 J. When in doubt, deliver the highest available energy dose. Question 27. During post-cardiac arrest care, a patient who remains comatose after ROSC is considered for targeted temperature management. What is the recommended target temperature range? A. 28 to 30 degrees Celsius. B. 30 to 32 degrees Celsius. C. 32 to 36 degrees Celsius. D. 36 to 38 degrees Celsius. Answer: C. 32 to 36 degrees Celsius. This question tests a specific detail of targeted temperature management, TTM, in post-cardiac arrest care. For comatose adult patients who achieve ROSC, the recommended target temperature range for TTM is 32 degrees Celsius to 36 degrees Celsius for at least 24 hours. This therapeutic hypothermia or targeted normothermia aims to reduce neurological injury and improve outcomes. Maintaining temperatures outside this range can be detrimental. For example, once a patient achieves ROSC and remains unresponsive, the medical team initiates measures to cool them down to somewhere between 32 and 36 degrees Celsius. Remember, this specific temperature range is crucial for optimal neurological protection. Question 28. A patient is experiencing severe anaphylaxis after receiving a medication. They are hypotensive and have significant angioedema and wheezing. What is the first-line medication for this emergency? A. Diphenhydramine. B. Hydrocortisone. C. Epinephrine. D. Albuterol. Answer: C. Epinephrine. This question describes a severe anaphylactic reaction, with hypotensive, angioedema, and wheezing as key indicators of a life-threatening allergic response. Epinephrine is the first-line and most critical medication for anaphylaxis because it addresses all major life-threatening components. It constricts blood vessels, improving blood pressure, relaxes airways, improving breathing, and reduces swelling. While antihistamines, like diphenhydramine, and steroids, like hydrocortisone, are adjunctive, they do not act quickly enough or powerfully enough to reverse severe anaphylaxis. For example, if a patient rapidly develops these symptoms after an allergen exposure, immediate intramuscular epinephrine is the life-saving intervention. Always think AP first for severe anaphylaxis. Question 29. You are performing CPR on an adult. What is the recommended compression to ventilation ratio before an advanced airway is in place? A. 15 compressions to 2 ventilations. B. 30 compressions to 2 ventilations. C. 10 compressions to 1 ventilation. D. Continuous compressions with 1 ventilation every 6 seconds. Answer: B. 30 compressions to 2 ventilations. This question assesses a fundamental aspect of high-quality CPR for adults without an advanced airway. The recommended compression to ventilation ratio for adults is 30 compressions followed by 2 ventilations, repeated in cycles. This ratio ensures that there is a good balance between maintaining blood flow through compressions and providing oxygen through ventilations. The other options are either for pediatric patients, not standard, or for when an advanced airway is in place. For example, after delivering 30 compressions, you would quickly deliver 2 breaths before resuming compressions. Always remember the 30-to-2 ratio for adult CPR without an advanced airway. Question 30. A patient presents with acute shortness of breath and an ECG showing new left bundle branch block, LBBB, with symptoms suggestive of myocardial ischemia. What is the immediate concern? A. Symptomatic bradycardia. B. acute myocardial infarction, MI. C. Stable angina. D. Pericarditis. Answer B. Acute myocardial infarction, MI. This question highlights a critical ECG finding in the context of acute symptoms. The combination of acute shortness of breath, suggesting ischemia, and a new left bundle branch block, LBBB, is considered a STEMI equivalent if clinical suspicion for MI is high. This means a new LBBB in a symptomatic patient should be treated with the same urgency as ST segment elevation, requiring immediate reperfusion. For example, if a patient suddenly has chest pain and a new LBBB on their ECG, they should be treated as if they are having a heart attack, and immediate arrangements for a cardiac catheterization lab should be made. Always recognize new LBBB with ischemic symptoms as a STEMI equivalent. Question 31. During resuscitation, what is the maximum recommended time to interrupt chest compressions for any single procedure, such as a rhythm check or intubation? A. 5 seconds. B. 10 seconds. C. 15 seconds. D. 20 seconds. Answer B. 10 seconds. This question tests a crucial guideline for minimizing interruptions during CPR. To maximize myocardial and cerebral perfusion, chest compressions should be interrupted for no more than 10 seconds for any single procedure, including rhythm analysis, pulse checks, or advanced airway placement. Prolonged interruptions significantly reduce the effectiveness of CPR. For example, when pausing to check the rhythm, the team should be ready to resume compressions immediately if no pulse or shockable rhythm is found within that 10-second window. Always strive for minimal interruptions, aiming for continuous compressions as much as possible. Question 32. A 35-year-old male with a history of hypertension is found unconscious. His ECG shows organized electrical activity, but no pulse is palpable. What is the initial pharmacological intervention? A. Atropine 1 mg 4. B. Epinephrine 1 mg 4. C. Adenosine 6 mg 4. D. Amiodarone 300 mg 4. Answer B. Epinephrine 1 mg 4. This scenario describes pulseless electrical activity, PEA, because there is organized electrical activity but no pulse is palpable. In adult cardiac arrest with a non-shockable rhythm like PEA, or asystole, the first-line medication is epinephrine. Epinephrine 1 mg 4 is given every 3 to 5 minutes, along with high-quality CPR and the search for reversible causes. Other medications listed are for specific rhythms or conditions: atropine for bradycardia, adenosine for SVT, amiodarone for refractory VF/private. For instance, as soon as PEA is identified, you would instruct the nurse to administer epinephrine while CPR continues. Always remember that epinephrine is the main drug for non-shockable cardiac arrest rhythms. Question 33. A 60-year-old patient presents with chest pain, ST elevation in leads 2, 3, and AVF, and is bradycardic, HR 45 BPM, with a BP of 90/60 mm of mercury. What is the immediate priority for this patient after initial assessments? A. Administer intravenous fluids to improve blood pressure. B. Administer nitroglycerin to alleviate chest pain. C. Prepare for immediate reperfusion therapy. D. Administer 0.5 mg atropine for bradycardia. Answer C. Prepare for immediate reperfusion therapy. This question combines elements of STEMI and bradycardia. The critical clue is ST elevation in leads 2, 3, and AVF, which indicates an inferior wall myocardial infarction. While the bradycardia and mild hypotension are concerning, the underlying cause is likely the MI, and the most time-sensitive intervention for STEMI is immediate reperfusion therapy, PCI or fibrinolysis. Addressing the bradycardia with atropine or hypotension with fluids is secondary to re-establishing blood flow to the heart muscle. For example, once the STEMI is identified, the immediate focus is on activating the cath lab or preparing for fibrinolysis, as this is the definitive treatment. Always prioritize reperfusion in STEMI, even if other issues are present. Question 34. What is the correct rate of chest compressions for an adult during high-quality CPR? A. 60 to 80 compressions per minute. B. 80 to 100 compressions per minute. C. 100 to 120 compressions per minute. D. 120 to 140 compressions per minute. Answer: C. 100 to 120 compressions per minute. This question tests another fundamental aspect of high-quality CPR. The recommended rate of chest compressions for adults is 100 to 120 compressions per minute. This rate ensures that sufficient blood flow is generated and maintained during cardiac arrest. Too slow a rate is ineffective, and excessively fast rates can compromise full chest recoil. For example, when performing CPR, you should compress the chest to the beat of a song like "Stayin' Alive" to help maintain the correct rate. Always strive for a rate of 100 to 120 compressions per minute. Question 35. You are considering using synchronized cardioversion for a patient. Which of the following rhythms is an indication for synchronized cardioversion? A. Ventricular fibrillation, VF. B. Asystole. C. Unstable monomorphic ventricular tachycardia. D. Pulseless electrical activity, PEA. Answer: C. Unstable monomorphic ventricular tachycardia. This question asks for an indication for synchronized cardioversion, which is different from defibrillation. Synchronized cardioversion is used for tachyarrhythmias that have a QRS complex and are causing instability, such as unstable monomorphic ventricular tachycardia, unstable polymorphic ventricular tachycardia with a pulse, and unstable supraventricular tachycardias, e.g., atrial fibrillation with rapid ventricular response, atrial flutter. VF, asystole, and PEA are cardiac arrest rhythms that are either defibrillated, VF, or not shocked at all, asystole, PEA. For example, if a patient has a very fast, regular wide complex rhythm and is hypotensive, you would perform synchronized cardioversion to try and convert it. Remember that synchronized cardioversion is for tachycardia with a pulse that is unstable. Question 36. A patient is in cardiac arrest. After several minutes of CPR, you note the end tidal CO2, EtCO2, suddenly increases from 20 millimeters of mercury to 45 millimeters of mercury. What is the most likely cause of this sudden increase? A. Deterioration of the patient's condition. B. Return of spontaneous circulation, ROSC. C. Inadequate ventilation. D. Esophageal intubation. Answer: B. Return of spontaneous circulation, ROSC. This question tests your ability to interpret changes in end tidal CO2 during cardiac arrest. A sudden, sustained increase in EtCO2, typically greater than 30 to 40 millimeters of mercury, or a significant jump from baseline, during ongoing CPR is often the earliest and most reliable indicator of return of spontaneous circulation, ROSC. This increase reflects improved pulmonary blood flow as the heart regains function and effectively delivers CO2 to the lungs. For instance, if the EtCO2 monitor suddenly shows a higher number, it's a strong sign that the patient's heart may have started beating effectively again. Always consider a sudden rise in EtCO2 as a key indicator of ROSC during resuscitation. Question 37. Which of the following is an irreversible cause of cardiac arrest in the H's and T's? A. Hypovolemia. B. Tamponade, cardiac. C. Tension pneumothorax. D. Thrombosis, pulmonary. Answer: there are no irreversible causes of cardiac arrest among the H's and T's. They are all potentially reversible. This question is designed to test your understanding of the H's and T's as reversible causes of cardiac arrest. All the options listed, hypovolemia, cardiac tamponade, tension pneumothorax, and pulmonary thrombosis, are classic examples of the H's and T's, which are conditions that, if identified and treated promptly, can potentially reverse cardiac arrest. The concept being tested is that ACLS focuses on identifying and treating these underlying conditions to improve patient outcomes. For example, if a patient has a tension pneumothorax causing cardiac arrest, needle decompression can resolve the issue and potentially restore a pulse. Always remember that the H's and T's represent treatable conditions that ACLS aims to correct. Question 38. A patient is in cardiac arrest and has a known history of severe hyperkalemia. Which medication would be indicated in addition to standard ACLS medications? A. Calcium chloride or calcium gluconate. B. Sodium bicarbonate. C. Magnesium sulfate. D. Dextrose 50%. Answer: A. Calcium chloride or calcium gluconate. This question asks about a specific treatment for hyperkalemia, one of the reversible H's and T's. In cardiac arrest with known or suspected severe hyperkalemia, administering intravenous calcium chloride or calcium gluconate is indicated to stabilize the cardiac cell membrane and reduce the risk of arrhythmias. Sodium bicarbonate, insulin with dextrose, and albuterol can help shift potassium intracellularly, but calcium directly protects the heart. For example, if lab results confirm very high potassium levels in an arrest patient, giving calcium is an immediate priority to counteract its cardiac effects. Always consider calcium as a direct cardiac stabilizer in hyperkalemia. Question 39. What is the recommended post-cardiac arrest oxygen saturation target to avoid hyperoxia? A. 90 to 94%. B. 94 to 98%. C. 98 to 100%. D. Maintain 100% saturation indefinitely. Answer: B. 94 to 98%. This question focuses on oxygenation goals during post-cardiac arrest care. After achieving ROSC, the goal is to maintain oxygen saturation between 94% and 98%. While hypoxemia, low oxygen, is detrimental, hyperoxia, excessive oxygen, 100% saturation, can also be harmful, potentially leading to oxidative stress and worsening neurological outcomes. Therefore, oxygen should be titrated to avoid both extremes. For instance, after a patient achieves ROSC, you would adjust the oxygen delivery device to keep their oxygen saturation within this narrow, optimal range. Always aim for a target oxygen saturation of 94 to 98% post-ROSC to prevent both hypoxemia and hyperoxia. Question 40. A patient presents with a history of cocaine use and develops chest pain, which is unresponsive to nitroglycerin. The ECG shows ST elevation in the anterior leads. What medication should be avoided in this situation? A. Aspirin. B. Beta blockers. C. Benzodiazepines. D. Morphine. Answer: B. Beta blockers. This question tests knowledge of specific considerations in acute coronary syndrome, particularly in the context of cocaine-associated chest pain. The key clue is cocaine use combined with chest pain and ST elevation. Beta blockers are generally contraindicated in acute cocaine-associated myocardial ischemia because they can cause unopposed alpha-adrenergic stimulation, leading to worsening coronary vasoconstriction and hypertension. Instead, benzodiazepines are often used to reduce agitation and sympathetic stimulation, and nitrates are used for vasodilation, but if symptoms persist, calcium channel blockers are preferred. For example, if you suspect cocaine is involved in a patient's MI, you would avoid giving a beta blocker to prevent worsening their condition. Remember to avoid beta blockers in cocaine-induced chest pain. Question 41. A patient in the emergency department suddenly becomes unresponsive. CPR is initiated. The rhythm on the monitor is a chaotic, disorganized waveform without clear QRS complexes. What is this rhythm, and what is the immediate intervention? A. Asystole, administer epinephrine. B. Pulseless ventricular tachycardia, perform synchronized cardioversion. C. Ventricular fibrillation, defibrillate immediately. D. Pulseless electrical activity, search for reversible causes. Answer: C. Ventricular fibrillation, defibrillate immediately. This question describes ventricular fibrillation, VF, characterized by a chaotic, disorganized waveform without clear QRS complexes in an unresponsive patient with ongoing CPR. VF is a shockable rhythm and requires immediate defibrillation. Synchronized cardioversion is for tachycardias with a pulse, and asystole/PEA are non-shockable rhythms. For example, if you see this wavy, erratic line on the monitor, the very next action is to charge and deliver a shock as quickly as possible. Always recognize VF as a chaotic rhythm that needs immediate defibrillation. Question 42. A patient with symptomatic bradycardia, HR 40 BPM, BP 80/50 mmHg, is unresponsive to atropine. What is the next most appropriate intervention? A. Administer epinephrine 1 mg 4. B. Administer dopamine infusion. C. Prepare for transcutaneous pacing. D. Administer magnesium sulfate. Answer: C. Prepare for transcutaneous pacing. This question addresses symptomatic bradycardia refractory to atropine. When atropine is ineffective or unlikely to be effective, e.g., in high-degree AV blocks, transcutaneous pacing, TCP, is the next immediate intervention to increase the heart rate and improve hemodynamics. Dopamine or epinephrine infusions are also options for symptomatic bradycardia if TCP is unsuccessful or as a bridge to permanent pacing, but TCP is usually the immediate go-to. For example, if atropine doesn't improve the patient's low heart rate and blood pressure, you would quickly apply the pacing pads and begin pacing to increase their heart rate. Remember, if atropine fails for symptomatic bradycardia, pacing is next. Question 43. What is the primary purpose of debriefing after a resuscitation attempt? A. To critique individual performance. B. To document legal aspects of the event. C. To identify system issues and improve team performance for future events. D. To assign blame for negative outcomes. Answer: C. To identify system issues and improve team performance for future events. This question focuses on the crucial role of debriefing in team dynamics and quality improvement. The primary purpose of a debriefing is to review the resuscitation event constructively, identify what went well and what could be improved, and uncover any system issues or areas for team performance enhancement. It is not about assigning blame or just documenting, but rather a learning opportunity. For example, after a cardiac arrest, the team might discuss how communication flowed or if equipment was readily available to make the next resuscitation more effective. Always use debriefing as a tool for continuous improvement, not for blame. Question 44. A patient has been receiving CPR for 15 minutes without ROSC. You are considering stopping resuscitation efforts. Which of the following factors would support continuation of efforts rather than termination? A. Prolonged downtime before CPR initiation. B. Initial rhythm of asystole. C. Presence of hypothermia. D. End tidal CO2 consistently below 10 millimeters of mercury. Answer: C. Presence of hypothermia. This question tests knowledge about factors influencing the decision to continue or terminate resuscitation efforts. While there are many factors, presence of hypothermia is a strong indicator to continue resuscitation, as patients with profound hypothermia can appear dead but have good neurological outcomes if rewarmed and resuscitated effectively. You're not dead until you're warm and dead. The other options, prolonged downtime, asystole, low EtCO2, are generally poor prognostic indicators. For example, if a patient is found frozen and in cardiac arrest, you would continue CPR and active rewarming, as their chances of survival are significantly higher than for someone with normothermic arrest. Always keep warm and dead in mind for hypothermic patients. Question 45. A patient develops acute, severe shortness of breath, followed by sudden cardiac arrest. ECG shows organized electrical activity but no pulse. A point-of-care ultrasound shows a massive right ventricular dilation. What is the most likely reversible cause? A. Hypovolemia. B. Cardiac tamponade. C. Tension pneumothorax. D. Massive pulmonary embolism. Answer: D. Massive pulmonary embolism. This question presents a scenario leading to PEA with a specific ultrasound finding. Acute, severe shortness of breath followed by sudden cardiac arrest and massive right ventricular dilation on ultrasound are highly suggestive of a massive pulmonary embolism, PE. A large clot in the pulmonary artery can cause acute right heart failure and obstruct blood flow, leading to PEA. While other Ts can cause PEA, the specific ultrasound finding points strongly to PE. For example, if you suspect PE, and the ultrasound shows the right side of the heart struggling, immediate interventions like thrombolysis or embolectomy might be considered. Always consider massive PE in sudden PEA with acute respiratory distress and right heart strain. Question 46. During resuscitation, what is the significance of inadequate chest recoil? A. It indicates the compressions are too deep. B. It increases myocardial perfusion pressure. C. It reduces the effectiveness of compressions by impairing ventricular filling. D. It helps prevent fractured ribs. Answer: C. It reduces the effectiveness of compressions by impairing ventricular filling. This question highlights a crucial aspect of high-quality CPR, chest recoil. Inadequate chest recoil means that the chest is not allowed to fully re-expand after each compression. This incomplete recoil creates negative intrathoracic pressure that limits venous return to the heart, thus reducing ventricular filling and subsequent cardiac output generated by the next compression. For example, when performing compressions, make sure you lift your hands enough to allow the chest to fully spring back up after each push, ensuring the heart has time to refill. Always remember that full chest recoil is just as important as compression depth and rate for effective CPR. Question 47. A 70-year-old male presents with lightheadedness, chest pain, and an ECG showing a third-degree AV block with a ventricular rate of 30 bpm. He is unresponsive to atropine. What is the appropriate next step for this patient? A. Administer adenosine 6 mg 4. B. Prepare for transcutaneous pacing. C. Administer amiodarone 150 mg 4. D. Provide immediate defibrillation. Answer: B. Prepare for transcutaneous pacing. This question describes symptomatic bradycardia due to a high-grade, third-degree, AV block that is unresponsive to atropine. Third-degree AV block means that electrical signals from the atria are not reaching the ventricles at all, so atropine is unlikely to be effective. In such cases, and when the patient is symptomatic, transcutaneous pacing, TCP, is the immediate next step after failed atropine to provide electrical impulses to the heart and increase the rate. For example, if a patient is crashing from a very slow heart rate caused by a complete block, applying pacing pads and starting pacing is critical. Always initiate pacing for symptomatic bradycardia unresponsive to atropine, especially with high-degree blocks. Question 48. What is the primary drug for treating symptomatic polymorphic ventricular tachycardia, PMVT, with a normal QT interval? A. Amiodarone. B. Lidocaine. C. Magnesium sulfate. D. Procainamide. Answer: A. Amiodarone. This question asks for the primary drug for a specific type of ventricular tachycardia. Symptomatic polymorphic ventricular tachycardia, PMVT, with a normal QT interval is primarily treated with antiarrhythmics like amiodarone, or potentially lidocaine or procainamide as alternatives, especially if unstable and cardioversion is not successful. Magnesium sulfate is typically reserved for PMVT associated with a prolonged QT interval, torsades de pointes. For example, if you encounter a patient with an irregular, wide complex tachycardia and they have a normal QT, amiodarone is the first-line antiarrhythmic to consider if the rhythm is stable, or after cardioversion if unstable. Always differentiate between PMVT with normal QT and torsades when selecting antiarrhythmics. Question 49. You are managing a patient with suspected acute coronary syndrome, ACS. The patient's pain is relieved with nitroglycerin. What does this response indicate? A. The pain is definitely cardiac in origin. B. The pain is definitely not cardiac in origin. C. The response to nitroglycerin is not definitive for cardiac origin. D. The patient has unstable angina. Answer: C. The response to nitroglycerin is not definitive for cardiac origin. This question addresses a common misconception in ACS assessment. While nitroglycerin can relieve ischemic chest pain, a positive response does not definitively confirm a cardiac origin, nor does a lack of response rule it out. Other conditions, like esophageal spasm, can also respond to nitroglycerin. Therefore, relying solely on nitroglycerin response for diagnosis is unreliable. For instance, a patient with heartburn might feel better with nitroglycerin, but that doesn't mean they're having a heart attack. Always remember that nitroglycerin response is not a diagnostic test for ACS. A full assessment including ECG and cardiac biomarkers is necessary. Question 50. During cardiac arrest, if intravenous, 4, access cannot be established quickly, what is the preferred alternative route for medication administration? A. Endotracheal, ET, tube. B. Intracardiac injection. C. Intraosseous, IO, route. D. Subcutaneous injection. Answer: C. Intraosseous, IO, route. This question focuses on alternative routes for medication administration during cardiac arrest. If rapid intravenous, 4. Access is not feasible or fails. The intraosseous IO route is the preferred alternative. Medications administered via the IO route have a similar onset of action and bioavailability to 4 medications and can be used for any drug and fluid that can be given intravenously. Endotracheal ET tube administration is less reliable and not preferred. For example, if you can't get in 4 quickly, drilling into the shin bone to administer medications is the next best option. Always prioritize IO access when 4 access is challenging or delayed during resuscitation.